All right, I'm gonna go ahead and get started, if that's okay with you guys. I'm a little under the weather, so hopefully my voice will hold out, but we shall see. 2 hours of talking is a lot for any person. I encourage you to try it sometime. It's not fun. Although I'll tell you, my sister-in-law, she does special education, specifically with like deaf education. That's like her specialty. And they were saying, you guys are aware of the Florida School for the Deaf and Blind over in St. Augustine? Ray Charles famously went there back in the day. They said it's funny because when they have teachers that go over there and teach for a while, they're signing almost like 100% of the time. And when they come back and have to actually like teach like their other students who do here, all of a sudden like they find it like their voice is like completely like kind of like they lose all endurance essentially. And so all of a sudden they're just like, man, I'm really tired after like talking for like an hour. Jeez. But anywho. So getting started, a couple of things to cover for the class. Welcome back to Pharm 2. I was a little concerned Monday because I went to the People tab in Structure and I found on Canvas there's like several people missing. I was like, did I scare them all away? I was like, oh no, but then it was the registration thing, so everyone got in eventually, so that's good. In terms of the syllabus, so a couple of things have changed in terms of the percentages for the assignments there. So you'll see, and you guys can see everything on the course, correct? Hopefully, yeah. So there's 3 assignments again, so 3 prescription assignments. Those are going to be the same. I'll show you how those will actually change a little bit. There'll be 3 quizzes to kind of bump down the percentages a little bit, so that way they're not so make or break, and then kind of bump up the test a little bit. Okay, so some people like that, some people don't, but we'll see how it goes. It's kind of the conclusion that we came to. And so, and hopefully everyone will get that 3% for being professional. It was a little hit or miss for some of you last semester, so everyone pulled through eventually. So in terms of the prescription assignment, this first one that I posted here is a good representative example of how we're going to try doing some that are from like more of an inpatient perspective. So instead of writing like an outpatient prescription, these are like inpatient orders you might write for a patient, right? So say in this case here, you're the admitting PA after a patient underwent a procedure, right? So you'll find that there's 5 different orders that are there. Typically the inpatient orders aren't as intensive in terms of the amount of information you have to include, and I'll show you that on the syllabus or the rubric. So if you scroll down past the outpatient script, you'll see here how we're going to be grading those components there, and then you kind of see an example on what this looks like, right? So again, obviously you put the information for the patient. You'll have just a one-time date and time of when the orders were written, so that way we can make sure we know when things are happening. You only have to write that once. You don't have to write it for every single entry here. And then basically just go through your orders there. And if you notice here, you'll have the actual drug itself. Any strength needs to be included there. So for instance, like the fluids, it's D5 with NS, with 28K, that's kind of the strength, essentially, that's the name of the drug. You'll include the route. Any time frames in terms of like how long to give it over is important to include there if that's appropriate. If you say IV push, anyone know how long that normally means if you say IV push? About 2 to 3 minutes or so. But otherwise, for certain medications, you can't give it that fast. You can cause some pretty significant reactions, right? So for instance, like vancomycin, this one says give it over 2 hours. Anyone remember why that is? A red man reaction, you can get that kind of whole body rash that can develop from infusing it too quickly. So include infusion times if that's appropriate. The route, obviously, you want to have on there as well. And so, for instance, this one right here, we're going to go through and we'll talk about some of these medications. Some of we already talked about. And so, again, it's a 12-year-old patient. You have multiple medications, some for mild pain, some for severe pain. Again, it's important if you have anything that's PRN, you have to include an indication on when to give it, right? It may seem obvious, but when you have 2 medications that are essentially could be for the same thing, you're giving instructions to the nurse on which one to give, right? So if I have 2 medications on the profile, say oral oxycodone and IV morphine, and they both just say PRN pain, well, the nurse needs to know which one to give, right? Because if he's making that decision independently, that's outside of their scope, and the Joint Commission really doesn't like that. So you need to be clear on when to give which one, right? And so that'll be part of the instructions in terms of what you'll include there. And also, if anything needs to be given at certain times, you would also include that as well. Start at whatever time, okay? So that should be pretty straightforward. Let me know if you have any questions on that one. Other than that, any questions on the course? I think otherwise it's pretty straightforward. It's kind of more of the same, just different topics we're going to be covering here. I believe, did I put the sticky board up on there? I did not. I'll put that up at the break so that way you can include anything. I think it's the same link as the last course, but I'll put that on there so you can ask questions as they come up. Nothing at all? Everyone have a good break at least? You guys don't seem especially lively after having some time off, but that's okay. It's the end of the first week. I'll give you some time for that. So starting off, we're going to talk about orthopedics and pain management. In truth, there's not a ton of meds that are specific for orthopedics, but it's oftentimes a complaint that will be associated with a lot of pain. And so this is my way of kind of piggybacking all the pain management stuff onto or into the curriculum here. And so why is pain management so important in terms of our patients? Yeah, it can help them heal better for sure. What else? Quality of life for sure. Like, there's a lot of disability associated with chronic pain, especially, but certainly some acute pain. Is there any issues of pain and treatment of pain in the U.S. perhaps? Yeah, there's a huge opioid epidemic that's going on there, right? So not only do we have prescription opioids being a really big issue, there's also big issues in terms of illicit use of substances, and a lot of patients don't just necessarily start off by injecting heroin, right, that may be laced with things like fentanyl. Oftentimes they are chronic pain patients who are cut off from access to their medications, right? So often they make that switch over in some cases there. So we'll talk about addiction. We'll talk about ways we can kind of go around that. If you want more information specifically on sort of the evolution of the opioid crisis here in Florida and also more abroad, I do have a lecture that I posted probably like a year or two ago. Actually, I gave it at the Winter FAPA conference, but I kind of posted like a dry run of it on my YouTube channel. And it's about opioid prescribing and PAs. You can check that out if you're curious about more information. I think it's a really fascinating topic, and it's something that you're going to be dealing with no matter where you go to work for probably the majority of your career. Because again, opioids are not something we're going to fix overnight, unfortunately. Anyway, so let's talk about pain management. What is pain? Can you objectively measure pain? No, that'd be nice, right? If you can figure that out, you'd be a billionaire for sure, right? At the painometer. No one's got that, unfortunately, right? But it's a very subjective sort of thing, right? Everyone's pain is a little bit different, and very frequently it is what the patient says it is, right? But are patients always truthful? No. In the tox world, you know how I can tell if patients are lying? If their lips are moving, right? It's a cynical approach to take, but is oftentimes the truth, right? Patients are embarrassed, or they're being, they're there for illicitly using substances, and they don't want to get in trouble. I mean, there's a lot of reasons why patients may not be truthful with you, and a lot of it could be related back to their, pain management in a lot of cases here, right? Not only that, but there's a lot of issues from the provider side of things as well, right? So I'm sure a lot of you will have some stigma kind of built into you, well, who should get opioids? Some people take a very hard line stance and say very few people should get opioids. Unless you come in with an obviously displaced fracture, you're not getting anything, right? There are some old school pharmacists who just refuse to fill any Schedule II substances, right? And it's unfortunate because there are patients who literally legitimately need this stuff, but they may not have access to it. So there's a lot of barriers associated with this, certainly fear of adverse effects, fears of addiction, all these things from kind of both sides of the equation there. So a lot of it may be related back to specific issues of the system itself, right? Maybe of lack of access for these patients to see actual pain management specialists, right? Very few practitioners, ER practitioners, family practice practitioners, don't really have a lot of specialized training on how to manage chronic pain. And so sometimes you may just take a shotgun approach to it. It may not be always appropriate in a lot of cases there. So we'll look at some issues with that. And then also there's a lot of poor reimbursement for it. So even if you had someone who specifically works in pain management, it may be difficult to get insurance companies to actually pay for that. Unless you're doing some kind of invasive technique, like placing, some kind of pump or any kind of thing like that. But basically, as I mentioned, it's a very subjective experience. You'll have patients that will come in, and what's the best way to kind of elicit how bad a patient's pain is? Yeah, pain scale, right? So what do you ask them? So you say, okay, on a scale of 1 out of 10, how bad's your pain, right? I like to add some descriptors to that. So I say, okay, 1 is like no pain whatsoever. 10 is like I'm, sawing your arm off with a dull spoon. Something, right? Something to kind of, because you can have patients that are sitting there like completely normal, vital signs are all fine. And like, what's your pain on the scale? 1 out of 10, and it's I'm an 8. And I go, you're an 8 right now. They say, yeah. I'm like, 8's like the worst pain, or 10's the worst pain possible. And they say, yeah, I'm an 8. Okay, great. But that may be legitimate for that patient, right? That may be just what they're actually experiencing. So it can be very difficult to tell. And that's why a lot of times we're moving away from just necessarily using a number and more so looking towards ability for them to perform tasks, right? So, can you go to work? Can you get up and clean your house? Can you do these different things? So we'll look at disabilities and whatnot in a little bit later on. But ultimately, it's true. It is whatever the patient says it is in a lot of cases. Certainly, we talk about types of pain. Acute pain is obviously going to be something that's usually pretty easily reversible or something that's very short-term in nature. Sometimes acute pain will turn into chronic pain, and for some patients it's persistent, it's always there, it's always around the clock. Sometimes it's going to be more intermittent, just depending on maybe they are a little more active and then all of a sudden the pain kind of crops back up again. And typically you talk about like malignant, non-malignant. That doesn't come up quite so often, but frequently, you think about like malignant pain is more coming from things that are more like life-limiting things, coming about from AIDS and cancer and things like that. And certainly you've kind of talked about etiologies of pain being more neuropathic, visceral, somatic, right? And we'll kind of lump how we treat these in terms of like neuropathic pains kind of has a different modality for treatment versus our somatic and visceral pain. We'll look at how those are going to differ in just a little bit here. Again, causes for acute pain, sometimes we're the ones causing the acute pain if they're going in for surgery. But again, typically it's pretty predictable. And we're going to see that treatment is going to be related around our analgesics, and we'll talk about different options for that. Chronic pain, though, is typically going to be more kind of multifactorial. You need to kind of go with a multimodal approach in order to manage that. So frequently patients who have chronic pain, they need to go to things like PT. Do a lot of them want to do physical therapy? Why not? It hurts. Why would I want to do something that hurts, right? And so that can be a big barrier to a lot of those things. They just kind of get into a sort of self-replicating cycle where they don't do the things that will help with their pain because it is painful in the first place. So it can be really difficult there. When I'm talking about like nociceptive pain, this is more somatic or visceral is kind of what we're talking about there. So if I cut your arm, that's going to be more of a somatic type of pain there. If you have something like appendicitis, that's more visceral, right? So something a little bit deeper there. Typically, we know it's like kind of sharp, dull, aching, throbbing kind of pain there. The neuropathic pain, though, being caused from the nerves will present differently, right? So if you have someone like a diabetic neuropathy, MS, all those kind of different conditions there that may present with neuropathic pain. Typically, you think about like the shooting pains, tingling, burning, those sort of things there, right? And so because it's different in terms of its pathophysiology, whether it's the nerves actually that are causing the pain versus the nerves that are just sending the pain from the area of injury, the treatment modality will change pretty differently between those two there. And it's pretty costly too. We know that people not going to work, we know that people having to go in for treatments for these things can be pretty deleterious in terms of its cost to society, cost to the people themselves, and big hit in quality of life. So I'm not going to kind of belabor the points there. But obviously, how to manage your patients well is going to be kind of looking at how do we assess their pain, right? And so we talked about a few ways, and you've already gone through all of your physical diagnosis for the most part. You know how to elicit pain. You know how to get a good history from the patient to determine kind of like, okay, where's the pain at? Does it radiate? Is it chronic? Is it new? Is it old? All these things you're going to be asking about them, and getting those characteristics of the type of pain that they're experiencing, right? I mean, try to elicit some of that pain to see, okay, is it still present now? How severe is it? If a patient's guarding, when you do an abdominal exam and they have appendicitis, things like that they're going to be looking for, right? Again, I want to kind of focus back on the pain scales because, again, the 1 out of 10 scale is not the only one that's there, right? Some patients you may want to ask a little bit differently. So, for instance, if a kid, say, for instance, you had, say, a 4-year-old, you're trying to ask them what's their pain out of 1 to 10, they may not really, get it, right? So, what are some other ways we could do that? Yeah, so you use pictures, right? Have you guys ever heard of the Wong-Baker Faces Scale? Right, so you've seen things like that. I kind of like the 10 centimeter visual analog scale. Anyone know how to use that? Basically, you tell your patient to say, okay, well, if you had to put your pain somewhere on the scale here where there's no pain whatsoever on the very left, and on the right, the pain is as bad as it possibly could be. Again, a lot of people use like childbirth, but again, that's something I'm never going to experience. I can't imagine what that's like, but I can use other things, other examples, and they can basically just kind of point to a thing there. The benefit of that, what do you think the benefit is? They don't see a number, right? So if they think, okay, well, if I say that I'm a 6, I'm more likely to get the medication that I'm looking for, then they can do that. Versus if they're just kind of pointing at a certain point, they can try, but they may not get as exact as they want. So point being is I can say they're right here about 8 centimeters over, I give them some medication, and all of a sudden they're kind of drift down to a 6. That's different. That's an improvement, right? So that's a change I can actually measure there in terms of the visual analog scale. That's not the same as just saying I'm a 6, right? So my wife, she did her second year residency in pain management at the VA, and it's interesting because some of these patients will really get tied, almost like part of their identity is tied to their pain number. So for instance, there's a guy, he was, a vet, and he had those chronic pain issues, and so they're coming in, they're checking him out, the team was, and they're like, well, what's your pain right now? And he says, oh, I'm a 6. Okay, that sounds pretty painful. He's been dealing with that for a long time, and so they do all these things to change the medication around. They, do all these things, and then they come back a couple days later and I say, "Well, how's your pain now?" They're like, how do you feel? And he's like, I feel way better. I feel great. I can get up. I can walk around. I can do these things. Okay, what's your pain? I'm 6. That's like part of his identity, like that pain scale that he was so associated with, and so that can be tough, right? So again, that's why you can look at things like, well, what can they do? Is their functionality improving? That can be a big thing to look at as well. Here's that Wong-Baker FACES scale. So again, if you had to, rate your pain in terms of like a face, kids can probably point to what they feel like at that time, right? My kid right now, she's 3.5. She's getting to the point where she can or reading books or something, and she can just like see like on this like cartoon pigeon's face, she's like, oh yeah, he's mad, like he's mad, and so she can tell, okay, that's sad, right? That's okay, I'm not feeling well right now. So that you can already start to see that sort of association there. Some people like geriatrics, you might use something like a thermometer. I'm sure most of you have probably never seen a mercury thermometer in their life. Possibly, right? But again, most of your older patients probably have, and so they're pretty used to something like this. So obviously you're looking for things that are modifying it, what makes it better, what has not. Very frequently, especially if you're not the first person to manage this patient, you want to find out what they have used before, right? Because you want to find out what has not worked for them, what has worked for them, because if they come in and they've been trying ibuprofen around the clock and they're still having pain, and you come in and say, I'm going to give you some more ibuprofen, they're going to say, well, what the point was why was I coming in the first place? Because you're not really doing anything else for me, right? So you want to find a lot of those features out. And again, obviously medication history is super, super important for these patients here. Find out what they're taking, find out what medications may be exacerbating their pain, things may be making it better, worse, etc. Very frequently, you have to ask about over-the-counter medications specifically, right? Why? They don't realize it, right? So for instance, if I were to say prescribe oxycodone, acetaminophen for a patient, but I didn't ask about how much Tylenol they're using at home on their own, what can happen? You get liver toxicity, right? So again, there's a lot of inherent issues with that, and so you have to ask questions, right? So you have to find out, okay, what specifically are they using at home, what have they used, what have they not used, etc. Obviously, in terms of labs, like organ function will be important for some of these, especially for more chronic uses. You're going to find some of these patients will accumulate metabolites of drugs that can lead to issues. You can find all kinds of problems here. And then talk about their history of substance abuse, right? Either not just themselves, but we know there's genetic links to addiction. We know that if they have a family member who is prone to addiction, they might also be as well. And we'll talk about the differences between like tolerance and addiction and things like that. And very frequently, you'll find a lot of these patients have some kind of behavioral health kind of comorbidity that needs to also be addressed as well. And very frequently, you'll find that things like pain can exacerbate things like anxiety, depression, and they can kind of cause the sick cycle. So by managing both, you're going to get much better effects than just by trying to treat the pain, right? So how you're going to manage these patients, especially with more chronic pain issues, is you'll find that they may have kind of a baseline basal level of pain that they're experiencing throughout the day, and then they may have the kind of breakthrough pain that occurs as well. So you have these like kind of spikes in pain that occur, usually due to activity and things like that. And so it's important to understand how to manage both of those. And so you may find patients who are on multiple pain medication, sometimes multiple varieties of the same medication, in order to manage their pain. So for instance, something like this, I would want to give a chronic med to kind of cover that baseline pain, say something that's extended release, something that's long acting, and then I can give them as needed doses for this breakthrough pain, right? So for instance, I'm sure most of you have heard of OxyContin before, right? It's controlled release, extended release oxycodone that is supposed to last 12 hours throughout the day. That is meant to provide kind of basal coverage for just the baseline pain, and then they may have an immediate release oxycodone they would take on top of that if they experience breakthrough pain. So that's that term there, that breakthrough pain, as it's kind of going above what the normal medication would be covering. Okay, you have to make sure you're addressing for both. We do this a lot in the post-surgical area where we have patients who are coming out. We have these spinal kids, they're having scoliosis surgery. Basically, they're putting in these like massive rods to straighten out their spine. It's a very painful procedure, and so we have a whole host of medications they'll be on afterwards. Some that are kind of around the clock to provide that basal coverage of pain, and then we'll have breakthrough pain medication for them as well, because we know that as they start to move around, things like that, pain gets worse, right? So how do we approach our treatment here? Sometimes it's based on etiology. Sometimes we'll go by this WHO ladder. The World Health Organization has this ladder that they have here, where basically you kind of want to start on the low end of things and kind of work your way up. So it's kind of like being a magician. Like, you know, when you are a magician, do you start out the show by sawing your assistant in half? No, you don't want to start the show with a showstopper, right? So you can start out by, like, I don't know, maybe pulling a scarf out of a hat or something, right? So start low, start with the easy stuff, and then kind of work your way up. Now, there's some caveats to that. If I have, say, a kid that comes into the ER and their arm looks like a swan's neck because they just broke it skateboarding, and I'm going to say, here, try some Tylenol. Let's see how that works, and then I'll give you something else if it doesn't. That doesn't work. They're going to be very mad at you, right? So, again, based off their presenting pain, you may have to start off a couple of steps above, right? So we'll kind of look at that. Basically, your early steps are going to be typically non-opioid sort of medications here, maybe some adjuvants. We'll look at some options there. And then as you work up, maybe oral opioid medications, you know, take a little bit longer to work, but they're going to be more effective than like an NSAID or Tylenol. And then finally, kind of jumping up to the top is where we're going to get a lot of our IV opioids, right? And so look at different options there as we go forward. So, again, not everyone has to start at the bottom step, so just be aware of how they're presenting, what their baseline pain is, and then kind of treat them as appropriate, right? So let's look back at inflammation, right? So we're going to look at all kind of the steps of the process here, how pain originates and how it actually gets transmitted up to the brain, and that way we'll see where the different medications are going to be working at specifically. So let's say we're dealing with some kind of somatic pain, say we have some kind of tissue insult, a trauma, a laceration, chemical irritant, anything like that. Typically what you're going to find initially is this kind of local inflammation sort of cascade that occurs here. We've covered this before, right? We've talked about allergies, we've talked about asthma. A lot of the same pathways are going to be occurring here. So you're going to see things like histamine, you're going to see things like serotonin and other inflammatory cytokines being produced there that are going to cause what at that site? What kind of the local effects? Vasodilation, right? So you can see swelling associated with that. What else? Redness, warmth, right? You may find itching associated with that, right? Because the histamine will sensitize those little nerve endings to be more sensitive, and you may have itching that can be developed with that. So along with that pain that's happening there, you see a lot of prostaglandins, which will be important for some of our classes of medications there, leukotrienes, etc. All are being mediated right there at the site, right? And again, they're trying to draw more inflammatory cells to the site as well to kind of propagate that system, right? And you're going to find that typically when you have these inflammatory cytokines being produced, that things like prostaglandins will lower that pain threshold, right? So they're making the fibers more likely to send those action potentials up into the brain to say, hey, something bad's going on here. You should probably take your hand away from the stove, or you should take your get out of the situation that caused that injury in the first place, right? And so you can kind of see here's the area of injury. Some other things like substance P and things like that can sensitize these nerve fibers to make them more likely to fire, and that will then be transmitted up through the spinal cord up into the brain, right? So your brain will process that and decide what to do, what kind of actions to take to deal with that particular pain, right? And so you'll see where different medications are going to be working at, whether they work at the site of injury or whether they work on this transmission up into the brain itself, right? So looking for anti-inflammatory agents, what we're going to be seeing here is that one, they will help with the prostaglandin and leukotriene synthesis. It will be decreased, and you'll see those changes start to reverse where we get rid of that redness and more of the edema and all of that that normally would develop in the inflammatory cascade. Our analgesics, though, are going to be useful, and specifically, how do we turn off production of prostaglandins? What are some ways we can do that? All right, so COX inhibitors, right? So what class of drugs does that? NSAIDs, right? So NSAIDs are going to be a big one, right? We're going to see our NSAIDs are going to be important for helping to decrease prostaglandin synthesis specifically. What other ways could I do that? Anything else that works to stop the inflammatory cascade? We've talked about probably steroids, absolutely. All right, so you could also use steroids potentially to help deal with that inflammation specifically, right? You'll find that the steroids themselves may not have analgesic activity, but certainly the NSAIDs will, right? So we'll look at some different kind of modalities for that. Again, just because someone gets a cut on their arm doesn't mean I'm going to give them prednisone for that, right? It doesn't really make sense, but certainly an NSAID will be useful because it will have some of those analgesic activity along with being anti-inflammatory. Typically, these kind of early steps here we're talking about are going to be for more mild to moderate pain, right? You still may use them in conjunction for more severe pain, but we'll see how we can kind of mix and match those drugs as we go forward. So as I mentioned, cyclooxygenase is going to be a big one here. We're going to see that, typically most of our agents are going to be reversible. Which one's irreversible? All right, remember aspirin's gonna be the irreversible one. Typically, you don't see a lot of aspirin being used for analgesia. A lot of people kind of moved away from that. And then typically the competitive ones, it's a fight at the receptor, right? So again, as I increase the concentration of drug, more of it's available to kick off whatever is trying to activate that cyclooxygenase itself, right? Now remember, there's two varieties. Yes, sir. Well, look at the side effect profile, right? So if you imagine, patients may develop tinnitus, they can have toxicities from having too much. Actually, I had a case the other night from the Poison Center. A lady had diverticulitis, pain associated with that, and she was chronically taking just a ton of aspirin every single day. And so she ended up developing this significant chronic aspirin toxicity. And anything, if you know about aspirin toxicity, is that, an acute ingestion can be really bad. A chronic one can be even more dangerous because it can kind of sneak up on you. So this patient had a significant mixed respiratory alkalosis with a metabolic acidosis. Even though her level wasn't particularly exciting, the metabolic effects it was having was quite significant, right? And there's a lot of chances patients may be taking aspirin without really realizing it, right? So I've talked about BC powders and goody powders and things like that patients may not associate with being aspirin. So overall, from a safety profile, typically NSAIDs are a little bit safer. That's why we see a lot more like Motrin and Aleve and things like that being used versus aspirin specifically. Most people think aspirin, they typically think cardioprotection. They don't necessarily jump to that as like a go-to analgesic. Not to say that's everyone, but that lady would be a good exception to that rule. But for some people, they kind of think just more NSAIDs typically, right? Anyway, so COX-1 versus COX-2. Remember, COX-1 is the constitutive variety, and constitutive just means what? Basically means it's always around, right? You're always expressing COX-1. COX-2 is inducible, which means that in areas of inflammation, you can induce the production of COX-2, right? So it kind of ramps up production when it's needed versus COX-1 is always around there, which is good. We want COX-1 around because if you remember back to our GI section, COX-1 is very important for producing that gastric barrier, that prostaglandins to help keep that mucus barrier that will protect our stomach from digesting itself, right? COX-2, though, is one that gets induced during times of inflammation. We'll see that by targeting one versus the other, specifically COX-2 for pain, that will have some interesting effects here and may be beneficial for some patients, as we'll see. Anyway, so treating pain based off of the etiology, here's kind of a general scope of things, how we're going to be shooting for this. So typically for somatic and visceral pain, which is probably, depending on where you work, the majority of what you're going to see, typically you want to think about starting off with things like NSAIDs, Tylenol. Now, is Tylenol anti-inflammatory? Remember, it's not, right? It doesn't have any anti-inflammatory activities. Antipyretic and analgesic, like the NSAIDs, but not anti-inflammatory, right? That's why you could use the two together, potentially. Corticosteroids also would fit into this picture here. And then you might use, plus or minus, opioids, okay? Notice here with neuropathic pain, opioids are going to be kind of our last stop. We typically don't like to treat a lot of neuropathic pain with opioids due to the side effects and issues we'll find later on. But this is where we can use things like antidepressants, anticonvulsants, and like muscle relaxants like baclofen. We'll get more into those drug categories as we get into like the neuro and the behavioral health section coming up. So we'll kind of briefly talk about it here, but we'll get much more into detail on those drugs at a later section in the class. So biggest things to know when managing these patients, you have to include both pharmacologic and non-pharmacologic measures here. There absolutely has to be a multimodal approach, including all kinds of different disciplines. Get everyone involved, PT, OT, respiratory. Everyone has to be involved in order to help manage these patients here. Behavioral, definitely get those guys involved, even if something's undiagnosed, maybe able to uncover something. And so overall, what we're trying to do is try to prevent, reduce, or eliminate pain. However, for some chronic pain patients, is it possible to eliminate all pain that they experience? No, right? So that's the big thing. You have to have a conversation with your patient and say, hey, listen, we may not be able to get rid of this entirely, but if I can get your 6 that you're experiencing day and night every single day down to a 4, that might be a big deal for the patient, right? That maybe allow them to get up and move around, do the things they want to do rather than sitting around in pain all day, right? And so again, functional capacity is really the biggest thing we're going to be looking for in terms of objective measures of how well our pain management is working for the patient. Can they do stuff that they couldn't do before is a pretty good measure versus just saying, well, how do you feel today? A 6, right? It's hard to tell what that really means, right? So again, the patients are going to be individualized in terms of how they develop their pain, how they experience it, so the therapy thereof needs to be individualized as well. And you'll see that patients will respond very differently between one another. You know, you have some patients who will, one opioid will make them sick as a dog and say, I just never want to take that again, versus other people may work totally fine, right? You know, patients have allergies, patients have previous history with drugs, so it's important to kind of figure out what's going to work for them. Frequently, multiple agents are going to be used, right? So we'll use different mechanisms to try to get some synergy there. And typically, if one approach doesn't work, we'll switch out and try to do something else instead, right? So some of our options here, we're going to look at acetaminophen, we'll look at our NSAIDs, opioids, and finally some of the adjuvants. Or when I say adjuvant, what does that mean? Yeah, something I can add on that can kind of help to enhance the therapy, right? So we'll get some adjuvants a little bit later. So starting with Tylenol, you gotta probably mention where the name Tylenol actually comes from. If you look at the acetyl P-aminophenol, that's where that comes from. So you can wow your friends with your knowledge of drug name origins. Now again, when do we use Tylenol? What's it good for? Fever. Okay, good. In terms of pain management, what's it good for? Got a headache, you know, maybe a little sore after working out, you know, mild to moderate pain, right? So very frequently, though, this is a good adjuvant. This is a good thing to add on in order to help out with other medications to work a little bit better. So for instance, for some patients, we will recommend maybe cycling between an NSAID and Tylenol. That way it provides better around-the-clock coverage potentially. We do like this for more chronic use as opposed to NSAID. So if I had to pick whether I wanted to give a patient, say, you know, a 60-year-old patient, Tylenol every single day versus an NSAID every single day, which one has a more favorable safety profile? Probably Tylenol, right? You don't have to worry about the GI issues. You don't have to worry about your bleeding issues. For the most part, as long as they're not getting too much Tylenol, it's not really going to be a big problem for a lot of patients there, right? So it's going to have limited usefulness and really severe pain, but it could be something you can add on. And in fact, now we have IV formulations that are available that get used pretty widely. So for instance, we have Pharm, which is the IV variety of acetaminophen. And while it's much more expensive than the typical tablet or suppository would be, we're now using it in things like post-operative settings or even prior to the patient going to surgery. And we do find that has opioid sparing effects. Anyone know what that means? I don't have to use as much opioids, right? When overall, especially in the post-surgical setting, the fewer opioids the patient has to get, the better, right? It means they're going to get up, they're moving around, their bowels are awake. So anything can reduce the number of opioids they need is going to be good for these patients. So again, we don't know the full mechanism why it's working, probably more centrally. So it's not really working at the site of inflammation, which is why it doesn't really have anti-inflammatory activity. But remember the dose-dependent effects here. No more than 4 grams a day. The majority of patients, if they have a history of liver disease, I probably wouldn't go much above 3 grams, right? Because you do know if you're taking this chronically, especially at these high doses, you're going to definitely see increases in LFTs. You can find kind of chronic liver damage just being done over time. And so you have to consider, though, and this is the biggest thing to note, is you have to consider all sources of acetaminophen, right? So if I'm prescribing a patient, or you're prescribing a patient hydrocodone and acetaminophen, and then they're taking acetaminophen on top of that, that's where they get into trouble. So consider all sorts, ask how much they're taking, or if you're prescribing something that contains acetaminophen, what do you tell them? Don't take anything else with acetaminophen in it, Tylenol in it, anything like that. Make sure they understand the difference between a brand name and a generic name. Make sure they these mean the same thing, right? So for instance, if you're giving them hydrocodone and acetaminophen, which is Norco or Lortab, 5-325 every 4 hours, and then they're taking 650 of Tylenol on top of that, it adds up very quickly, right? So they can easily get above the max amount that they should be receiving. Okay, so the NSAIDs, we know they're analgesic, antipyretic, anti-inflammatory, all have really good actions there. We do know there's several that are over-the-counter. Which ones do we have over-the-counter most frequently? Ibuprofen, which is Motrin, right? Aleve, what's the generic for Aleve? Naproxen, right? So those are the 2 most common ones you're going to run into. Again, aspirin still falls in this category, but we know that the side effect profile is a little different there. And again, most of these ones we have are going to be non-selective, meaning they affect COX-1 and COX-2 equally, okay? We'll look at a few COX-2 inhibitors specifically and some of the caveats with that, but for the most part, most we have are non-distinguishing between COX-1 and 2. And again, looking at this process here, remember, as we have phospholipase A liberate some of these membrane phospholipids from the cell, it turns into arachidonic acid, and this is where COX-2, especially in the site of inflammation, so at the actual site of injury, COX-2 is going to be induced, it'll be ramped up in its production, and will block this conversion, or NSAIDs will block the conversion of arachidonic acid into thromboxanes and prostacyclins and prostaglandins, all those things, right? So that's where these are really going to be working, which is why NSAIDs tend to work when you have that inflammation, because they are able to affect that COX-2 that has now been induced as a result of the inflammatory cascade, right? So we have several that are available over the counter, as I mentioned, so aspirin, ibuprofen, naproxen most commonly. All the other ones are going to be prescription only, and I'll cover a few of these, but certainly there's a big list of them. Anyone know what like a really good go-to like IV NSAID is? You've like worked in like a scribe as an ER. Ever heard of Toradol before? Toradol is an NSAID, and it's ketorolac or ketorolac, however you want to pronounce it. And so that's probably like your bread and butter. If you work in urgent care or work in the ER, that's like your bread and butter IV NSAID, right? You can use IM, IV. And so has very good effects, very strong analgesic, anti-inflammatory activity there. You'll get used to using that one very frequently. Again, there's no clear advantage to one over the other. Some patients may have intolerances to one, may have to necessitate switching over to another one. And again, be aware of the different varieties of dosage forms you have available to you. So for instance, we have IV forms of ibuprofen available, but it's more expensive. We don't really use it a whole lot. Everyone just uses Toradol. So we kind of get a feel for the flavors of NSAIDs you're going to use as you're out there on clinical rotations and working, right? Typically, when you use them chronically, give it 2 to 3 weeks or so to see how the patient will respond, and then depending on side effects, depending on tolerability, you may end up switching to something else. Now, what are the big side effects we see with NSAIDs with chronic use? Yeah, you worry about the GI effects, right? So you worry about peptic ulcers that can develop here. Again, that is due to that COX-1 inhibition that is occurring when you're using a non-selective agent here, decreasing mucus production, decreasing that the production of that barrier that protects the stomach from eating itself, essentially. We know there's bleeding risk. Is this a reversible phenomenon for the most part, or irreversible? It's reversible for a lot of them, except for aspirin, right? So if I give a dose of ibuprofen, while the ibuprofen's in the system, there is some antiplatelet activity, but as soon as the drug is out of the system, the bleeding risk goes back down, right? So that's kind of the big caveat with aspirin. That is irreversible versus the other one's going to be reversible, right? And some patients may be more prone to hypersensitivity reactions. Remember, if you block that COX enzyme, instead of producing prostaglandins, everything gets shunted over into the leukotriene pathway. That's why you can see things like asthma exacerbations can occur from patients who are allergic to ibuprofen or allergic to aspirin. A lot of it is having that shunting over to the leukotriene pathway, and that's what's actually is occurring there. So if you ever see that, that's what's going on. NSAIDs will also prolong gestation. It's an important thing to know. So for instance, the prostaglandins normally stimulate the uterus to cause contractions. And so if you lose those prostaglandins, you'll end up seeing you can actually prolong labor. So actually, NSAIDs become a category D drug, meaning they have very, you only use them if the risks are outweighed by the benefits. So we're going to avoid those in a lot of pregnant patients, especially towards the 3rd trimester. And not only that, but you can see some abnormal or adverse fetal effects, or actually close down the ductus arteriosus prematurely, which is not great. So again, not going to be good for more late stage pregnancies. So I mentioned the asthma and the bronchospasm. Be aware that some patients with liver disease may have a hard time clearing this, so they may want to, may use lower doses or pick something else for those patients there. And then just be aware of what effects the NSAIDs are going to have on renal function, right? What happens there? Remember that, talking about efferent and afferent arterioles. I remember that when you're looking at the glomerulus, right? Everything's getting filtered through in the kidneys. You have the afferent arterioles that are coming in. What keeps those open? Prostaglandins, right? So if I give an NSAID and I get rid of that, those afferent arterioles are going to close down to some degree, and that may may decrease our GFR. So because of that, you have to be careful. Patients who have chronic kidney disease, patients who are dependent on those prostaglandins, if you get rid of those with an ibuprofen or an naproxen, that's going to cause an acute decrease in their GFR, right? So we mentioned aspirin being the irreversible inhibitor there of COX-1 and COX-2. Any patients I should be really worried about using aspirin in? Right, which kids? Yeah, they've had a recent viral illness, something like that. You don't want to use aspirin. Why? Yeah, you get that Rhea syndrome. What is Rhea syndrome? it's that fatty liver encephalopathy that can develop, right? And so again, if you catch it early, it's manageable, but if you let it keep progressing, then it can be quite fatal in a lot of cases there. Remember that the dose is going to be kind of limited in terms of aspirin, how far you can push that, because you will end up seeing some significant effects there, right? In some patients, even at normal therapeutic doses, they'll still get that tinnitus, right? They'll still experience that earring. Sometimes even hears like a muffled kind of sound. I remember at one time I was working I was during my fellowship, and we would staff in the poison center ourselves. So I'd be taking all the phone calls that would be coming in. I remember one patient, a young lady who had actually overdosed on aspirin, and I was trying to get history from her before we called EMS to come pick her up. And I remember talking to her. I said, "Okay, well, how much did you take?" She's like, "What? How much did you take? What?" Could not hear me at all because the aspirin was kicking in, and her hearing was so muffled that she couldn't even understand what I was saying, right? So again, I was like, okay, this is probably pretty serious if she's experiencing all this. But again, going up higher and higher doses can be quite dangerous, right? So you can see a lot of respiratory, metabolic acid-base disturbances that happen here, and eventual very severe toxicity. So this is, again, another good reason why not to recommend really routine use of aspirin, because in terms of its overall safety profile versus other NSAIDs, those are going to win out for the most part. There's no real clear benefit to using salicylates here. Again, we will typically not use it a lot in pregnancy. It may help with preeclampsia to some cases there, but again, it's going to be on a very, very case-by-case basis, and we talked about the Rhea Syndrome risk being there as well. Are quite fatal if not caught and treated early, and again, it can mimic a lot of the same early signs and symptoms of a viral illness anyway, so it could be very hard to distinguish between, hey, the kid's just sick versus actually have something really serious going on. Okay. So then a lot of our other NSAIDs get lumped into what we call these propionic acid derivatives, and it just has to do with the chemical structure of the drug itself. This is going to include a lot of things like our ibuprofens and indomethacins and things like that. Again, most common uses for it include things like arthritis, myalgias, dysmenorrhea, things like that are going to be most common. The big differences between these are going to typically be things like duration of action. How often you're going to have to take these is going to be kind of the big differentiators between all of them. So for instance, looking at something like ibuprofen has a fairly short half-life, say only 2 hours or so. And you know how often you typically dose ibuprofen around the clock? Every like Q6 to 8 hours, right? So again, it's fairly frequent dosing versus something like naproxen, a lot longer half-life. This one may only, that's like their big claim to fame in all the commercials, right? Like all day long, all day strong, or something like that. So it has a longer half-life. You'll have to take it maybe once, perhaps twice a day, and that way you'll provide better coverage overall. Something like oxyprozin, Daypro, even putting it in the brand name there, has a very long half-life. You only have to take one pill a day in order to get kind of around-the-clock coverage. And again, overall, their safety profiles, side effect profiles are going to be very similar. You may find that patients may not respond well to one. You can switch over to another one, right? So again, it just depends on how they're going to react to it on an individual basis. So just to give you a couple examples of ones you may use more specifically, things like indomethacin. Again, you're going to find that these are all reversible inhibitors. Most of these are going to be non-competitive. We'll talk about a few examples where they are going to be a little bit more selective for one isoenzyme of COX versus another. This one's interesting. We used to use indomethacin a lot IV to actually close a patent ductus arteriosus. So you'd have these NICU kiddos that would be coming in, and their ductus arteriosus would remain open, and we could actually use chemical means to try to close that, and then we'd actually give an NSAID because that would get rid of the prostaglandins that would actually keep that open, and so then it would close down. And if that didn't work, then you have to go in and do it surgically, but we'd use things like NSAIDs for the most part as a kind of initial step. Anyway, remember, this is going to make things like diuretics not work as well. Again, why is that? Yeah, the effects of prostaglandins on that afferent arteriole, less blood is getting into the glomerulus, less fluid you can get rid of with your diuretics, right? So that kind of makes a lot of good sense. Typically, shorter courses of NSAIDs are going to be better because of the GI effects, right? So if we can try to prevent that, it's always going to be beneficial. Now, Toradol, as I mentioned, is our go-to IV NSAID or IM NSAID for the most part. A lot of patients who are coming in with pain to the ER, they're going to get this, right? It may be your first step before you go and give some morphine, or you may give them the two together. It just depends on the case here. But it is opioid sparing, so you overall may not need opioids or may need less doses for it. However, the GI effects tend to be quite severe, and so it does have a black box warning for that. And in fact, most places will only limit its use to just 5 days, right? And so, for instance, if you go into your, I'm not sure about Advent Health, but I know at least at like Nemours, they automatically build it in, so you cannot give more than 5 days, right? Because of that adverse GI effects there. Just some other ones we have here, things like Piroxicam. Again, based off their duration of action, things like that, it will help with compliance in terms of how frequent the dosing is going to be. We'll look at some other options here. They're going to be a little bit more selective. So, for instance, Meloxicam here, or Mobic, has a 10-fold selectivity for COX-2. So what do you think kind of benefits you're going to get from that? Switch effects? Yeah, the GI effects are going to be the big thing you're sparing there. So if you have a patient who has a history of, say, peptic ulcers or any kind of GI bleeds or anything like that, especially due to NSAIDs, using something that's a little more COX-2 selective is always going to be beneficial for those patients, okay? So Meloxicam is going to be the first one here. It still has some COX-1 activity, right? So it's not going to be devoid of those side effects, but it's going to be more selective for COX-2, that inducible form. And thus, it's going to be a little bit safer from a GI perspective. Okay? Yes, sir.
Is there more risk with MI and stroke?
There is. We're going to get to that in just a few moments. Thank you for a great segue into that. Some other ones we have here, things like diclofenac or Voltaren. This is another one's moderately selective for COX-2. This one's neat because it comes in a topical formulation. So you have like Voltaren gel. And so what do you think the benefit of using a topical product would be? You limit a lot of the systemic action. So if I had someone, like an older patient, maybe an older chronic kidney patient, and they had some pain, say, in their left knee, and I don't need something that's going to be working systemically, maybe just that topical gel might be the good option for them, because it limits systemic absorption. You only get action at the local site. I don't have to worry about the kidneys being affected, the stomach being affected, etc. So that can be a really nice benefit from that standpoint. So getting into COX-2 inhibitors, by selecting or being more selective for COX-2, we find that you do decrease the incidence of GI ulcers, right? Which is a good thing. However, the concern is with the cardiovascular risk, as you so correctly mentioned. The reason for that is because we see that when you're looking at the actions of prostacyclins and prostaglandins, that there's a kind of a balance between the prothrombotic and the antithrombotic effects. Not only that, but COX also has activities with angiogenesis and producing new blood vessels. So we had a drug that came out, unless you probably have never heard it. This is like old school news by the time I was in pharmacy school, which I just realized was 10 years ago coming up, and that feels bad. But there was a drug called rofecoxib, or Vioxx, and Vioxx came out. It was this like blockbuster, brand new drug. They're like, this is going to be the thing that revolutionizes pain management because it's COX-2 selective entirely, does not have any GI effects. This is going to be fantastic. And what did they find? Well, they found an increase incidence of MI because of the fact that they were getting more prothrombotic effects. They were having issues with angiogenesis happening because you're just targeting that COX-2. But they only realized that once the drug got out into the mass market. How come they didn't figure out in clinical trials? Well, how many people are involved in those clinical trials? A couple thousand, maybe? Well, when you get out into the mass market, how many people are getting it? Millions potentially, right? And so again, you don't find a 1 in a million side effect unless you give it to millions of people. So they started to notice there's this increased risk for MI, and they actually pulled the drug off the market, right? So they went ahead and just FDA came in and said, nope, you gotta take this out, and they removed it completely, right? And so there's a ton of like, you ever see like those daytime like lawyer ads, or like, has your family member been affected by this drug, blah blah blah, causing this side effect? There was like those ads like for forever for Vioxx, because of the potential recuperation. They wanted to make money off the situation, as it turned out. But you're going to find that we don't have any pure COX-2 selective agents anymore. Now what we're going to use is something a little bit more moderately selective for COX-2, but still has some COX-1 action. So for instance, kind of the one that has the most activity for COX-2, most selectivity I should say, is Celebrex or celecoxib. Even though we've been giving this to millions of people, we have not seen that same adverse effect profile. So this strikes a nice balance. So you don't want to get any more selective than that, because otherwise that risk for MI does come back. So again, much more limited GI side effects. And again, Celebrex is the only one on this list that's really going to get used for the most part. So if I had a patient with a history of peptic ulcer disease, this might be a good option to go with. If I have a patient with a history of previous MI, I still may be a little bit more cautious, right? It's not to say it's an absolute contraindication, but it's a relative one for sure. You can kind of see here, we had a few that were just the most selective here. Those are all the ones that caused a lot of MI. Celebrexo tends to have the nice balance there, no increased MI. We still have this on the market, right? Any questions off from the first half? A little bit of review, a little bit of new stuff. Now let's get to the good stuff, right? Let's set that first hour. Now I'm going to get all the good drugs. So let's talk about our opiates. Now, what are opioids? Where do they come from? Anyone know? Anyone know what that plant is? The poppy plant, yeah. It's the Papaver somniferum is the scientific name for that plant there. And basically, that is where we originally got a lot of our opioids from. That is not the only place we get opioids from now. We have a lot of synthetic means to produce those, and we'll talk about those different classes of meds just a little bit. But basically, anything that interacts with the mu, kappa, or delta opioid receptors in our body are considered to be opioids or opiates, right? There's a little bit of distinction between those two terms. You'll probably hear me use them interchangeably there. You may see them referred to as OP1, 2, or 3. That's kind of a little bit newer nomenclature, but I still see a lot of people using mu, kappa, and delta there. Now, again, we're going to find that, actually, like, going back to the poppy, can you pop positive on a urine drug screen from a poppy seed muffin?
Yes.
Or a bagel? Yeah. Is it likely?
No.
No, you have to eat a lot. Like, just get, like, you know, the bottom of the bagel bag where, like, all the little bits at the bottom, like, maybe if you got, like, a bunch of those, you may show positive, but yeah, but it's possible, right? So, you know, I'd be a little dubious if I had a patient who's claiming that was the cause, right? But anyway, you can do confirmatory testing. These are good for more moderate to severe pain, right? So you stub your toe, you're probably not going to get any morphine for that, right? But however, if you have a displaced fracture, absolutely, right? So that's a good reasons to in order to manage that pain there. Yeah, maybe you like stuff the whole thing with little poppy seeds, perhaps. Like, yeah, maybe. Anyway, and so, you know, we have these receptors. Like, what normally would interact with these receptors that our body produces anyway? Because we have the receptors, like, something has to be a natural ligand that our body produces. Otherwise, why would we make the receptors? Well, we have natural opioid-like products that we produce, things like enkephalins and dynorphins and things like that. Our own natural sort of body's analgesic system, right? So you ever heard, like, the runner's high, right? The only high I ever got was not running whatsoever, I'll tell you that much. But some people claim that if you run long enough, you get this runner's high, and it's thought to be mediated through a lot of these opioid receptors and natural endorphins that your body would normally release, right? So there's something to that. Now, again, the opioids are not going to be working at the actual site of injury itself. What it is going to be doing is working on the signals being transmitted from the source of pain up into the CNS. So you're going to find that predominantly they're going to be working here on these ascending pathways in the spinal cord. There's going to be some mu receptors here, and then up in the CNS as well. Those are the primary spots where your opioids are going to be working. They don't do anything about the pain at where it's originating. They don't do anything for inflammation, anything. These are pure analgesics, okay? So, and again, I don't have a lot of experience with opioids. I think when I had my wisdom teeth taken out when I was a kid, like, I got some like Darvocet, which is like really puny kind of stuff. But someone was saying that it's like, you know, you still know you have pain, you just don't really care about it so much. Like, it kind of blunts that perception of the pain as those signals are being blunted as they're traveling up through the spinal column, right? And so, primarily what we're going to focus on is the mu receptors. Kappa and delta are important, and different drugs may interact with those, and they can be responsible for some things like dysphoria and some proconvulsant activity, things like that. The main one that we're concerned with is the mu opioid receptor, because this is primarily where you get most of your therapeutic effects, and this is where you get predominantly a lot of your adverse effects. Okay, so the therapeutic effects are going to be the analgesia you get from that. What are some of the side effects you might end up getting as a result of opioid use? Constipation, right? That's through the mu receptors. What else? Respiratory depression, absolutely, through the mu receptors, right? Working on the brain stem, depressing our respiratory center. Euphoria, right? So that can be an intended or unintended side effect, depending on what the use is, right? But that euphoria you can get from that. All those things are going to be mediated through that mu receptor, and that's the primary one we're going to be focusing on, right? So basically, we're going to find that different drugs will work differently at these receptors here. So we can have some things that can be a full agonist, meaning it has 100% activity at that receptor. We can have things that are just a partial agonist. We'll talk about where that may be useful. Some of them have kind of an agonist-antagonist activity. We're not going to focus on that one so much, but then we certainly want to know about what the antagonist is, right? And we know what the opioid receptor antagonist is? Narcan, right? Or naloxone. That one's very important to know. Why? Because that can save someone's life, right? So again, if you're having significant respiratory CNS depression from an opioid, this is the thing that's going to be able to reverse that and have them come back out of it, okay? Agonists in terms of pain management are what's most frequently going to be used for these patients here, okay? So looking at this, there's a couple different terms that I want to focus on. It's important to kind of make the distinction between these, and especially when you're educating patients, because you'll have some patients, you'll say, okay, well, you have obvious pain, I want to give you an opioid for this, and they'll say, no, thank you, I don't want it. You say, why? Because I don't want to get addicted to it. Again, not everyone who's going to be on opioids is going to become addicted, right? A lot of it has to do with genetics and their own particular reward pathways and things like that. But let's look at some of the different factors here. So we're going to talk about physical dependence, talk about tolerance, addiction, and then pseudo-addiction as well, and kind of what the differences are between those. So when I say physical dependence, what does that mean? So yeah, they've been taking it for a while, right? And the body, now again, we know the body likes homeostasis, right? We like the status quo. Well, if I introduce these medications on board, your body gets used to that over a period of time, and that is the new normal, right? So once that is the new normal, you now have a physical dependence on the presence of that drug. If I try to take that away, what happens? They have withdrawal, right? Withdrawal can manifest in a number of different ways. They can have things like diarrhea, because now the guts are starting to wake up again after losing that opioid effect, causing constipation normally, but now it's kind of getting the reverse effect. They can get very agitated, they get anxious, they get sweaty, they get runny noses, they feel miserable, right? And so what do they want at that point? They want more of the drugs, right? So again, drug-seeking behavior may be simply that physical dependence manifesting, saying, hey, I need to get this drug back to get me back to my normal, right? So again, people may have different motivations based off of how they're behaving, and some of it could be related to this physical dependence there. Now, everyone who takes an opioid chronically will have physical dependence to this, right? And how would you deal with that? How would you say you want to get a patient off of an opioid? How would you deal with that to prevent those kind of withdrawals? Slow tapers, right? That's really the biggest thing, is to slowly taper them. And we can see this in patients all the time, like even patients who are not taking for chronic pain. Imagine you're working up in the ICU and you have a patient who's been ventilated and sedated for the past week, right? Say after a car injury or something like that. When you're starting to wean them off their medications, they can have those same withdrawal symptoms, right? You have to slowly wean them off of it. We have a lot of babies in our NICU who are withdrawing from opioids, right? What do you call that? That neonatal abstinence syndrome, right? The moms have been using opioids all throughout the pregnancy. The babies are born, and now they're cut off from their source of opioids. They withdraw just the same as any adult patient does, and so we have to wean them off of it too, right? We have to give them things like methadone in order to wean them off to get them back to what their baseline should be without the presence of those drugs, right? So again, it's all physical dependence. Yes, ma'am.
If you wean them off slowly, is there still a chance that they can withdraw?
Yeah, and sometimes you have to end up slowing down the wean period. Sometimes that has to go over the course of weeks to months potentially. It just depends on the patient, yeah.
If the mother's like not honest for some reason, or is like denying that she was on drugs, is there some way to like lab be able to tell exactly what the baby's withdrawing from?
Potentially, yeah, you can do things like urine drug screen on the infant, to determine perhaps what might have been in their system. That can give you sometimes a clue, right? Because it's not just opioids, right? Sometimes it is cocaine, sometimes it's benzos, sometimes alcohol. For the most part, though, the management is going to be similar, though, right? Because again, the babies all kind of look the same, and you can manage it all the same as well. And we'll kind of mention that a little bit later on in the pediatric section of how we can manage that. But you can sometimes do that. Although sometimes laboratory tests can be false, right? Did I ever mention the babies that were shown positive for marijuana in their system? So there was a hospital, and basically these babies were coming out. I guess it was routine practice for them to test the baby's urine to see if there's any drug present there, right? And so these are maybe a couple days, a week old babies, and they were testing them, and they were showing positive for THC. And so they went back to the mom. They said, like, hey, why is your baby showing positive for THC? You must have been using it. And the moms were like, I've never touched this stuff. Like, what are you talking about, right? So then they test the parents, the mom, and presumably if the baby's positive, the mom should be positive too, right? Because that's the only place the baby could have got it. Moms are negative. They said, wait a second, what's going on here? So they're trying to discern why in the heck these babies are showing positive. I mean, it's not like they go to the nursery and start lighting up joints or something, right? So what they ended up finding, there was a moisturizer that they were using, a particular moisturizer that had, and again, remember, baby's skin is quite thin, right? So they can absorb things much easier than adults can. They were absorbing this compound that happened to trip the assay that looked like THC, even though it really wasn't, right? So again, don't always trust laboratory ads. That's a pretty extreme case there, but again, kind of illustrates the point that, take some things with a grain of salt, right? Labs are not going to always tell you the answer. But regardless, though, withdrawal from an opioid, it's not fatal, right? No one's going to die from this. They're going to wish they were dead, because they feel so miserable, but no one's going to die from withdrawal from an opioid. So that's an important distinction there. As opposed to something like withdrawal from alcohol or withdrawal from like a benzodiazepine, like Ativan or Xanax, can those be fatal? Asking the question. So yes, absolutely they can be, right? You can have withdrawal seizures, and this absolutely can be fatal. So that's kind of the big difference there, right? So withdrawal from CNS depressants like alcohol, benzodiazepines, barbiturates, we'll get into all of those later, can be fatal. With opioids, not the case, okay? They're miserable, but they're not going to die from it, okay? Anyway, so it's a frequent, common occurrence. You know it's going to happen with any chronic use of opioids. However, it's not correlated necessarily with addiction, okay? So kind of keep those two things in mind differently. Everyone may become physically dependent. Not everyone will become addicted to opioids. Okay. So addiction, what is addiction, if you had to define it? I see common definition of basically being use despite negative consequences, right? So if you know that you're not going to be able to get up and go to work and you lose your job because you decide to use opioids instead, that would be considered addiction, right? If you decide not to buy groceries for your kids so you can go buy some more oxycodone, that would be considered addiction, right? So use despite known negative consequences thereof, right? They have this compulsive use. They will use despite harm. They typically will have a lot of craving sort of behaviors in order to get more of that medication there, right? It was really interesting. I was doing a class for a pharmacy school, and it was about drugs in society, and we were talking to a couple of officers from FDLE, Florida Department of Law Enforcement, and they were there when, then it goes, if you don't know the history of it, again, I suggest watching that video I have on my YouTube channel, but there is, hit that subscribe button while you're at it, and like, and comment. No, I'm just kidding. But anyway, we had these officers that were coming in, they were talking about the pill mills that were such a huge problem in Florida. And if you ever heard of the OxyContin Express? OxyContin Express was basically this pipeline of prescription opioids that originated in Florida. It was typically being funneled up through Virginia and Kentucky and places like that, right? It was a huge source for the opioid epidemic that was happening here. You'd have people by the busloads coming down, going to these physicians' offices where they were getting illegitimate prescriptions for hundreds of tablets of opioids, filling them at pharmacies where frequently they were in kind of cahoots with the providers, and then shipping them back up and then disseminating them throughout the country, right? So it was a huge problem, and several years ago they finally cracked down on it and said, we're going to get rid of all these pill mills, right? And so we were talking to some of these officers who were actually going undercover and going into these offices, and it was so interesting getting their take on it. They had pictures too, and they would show these, random doctors' offices in the middle of a strip mall, and you'd have people lined up around the building waiting to be seen by that provider. You'd have cars in the parking lot that were from all different license plates from all over the country, right? Because they knew they can come here and get these easy to acquire prescriptions. And then you go in, they had pictures where they're actually in the waiting rooms, and people were just like passed out in the middle of the waiting room because they were still under the influence of the opioids themselves, right? And so they talked about several of the physicians that they actually busted for it. A lot of them had guns in their offices. I don't know if you know this, but most doctors' offices do not contain guns. They had one doctor who was actually trading sexual favors for opioid prescriptions. So he, in his lab coat, had a pocket full of condoms. It's awful stuff, right? But this is what addiction does, right? They will do nearly anything in order to get back to their normal, to get that medication back. So fortunately, we've clamped down on a lot of that. So we clamped down a lot of the prescription opioids that were coming out of Florida. But now, does that mean that everyone who was addicted to opioids before just says, well, I guess that was a good run? Not addicted anymore. Where do they go to now? Heroin, right? Heroin has had a huge uptick in Florida since then. And not only that, but a lot of the heroin's actually laced with opioid we're going to talk about in a little bit called fentanyl. Right? So we're seeing a ton of fentanyl deaths associated with illicit use of things like heroin. So anyway, point being, addiction, not everyone's going to have it, but some people are just wired. That dopamine pathway, that reward pathway, they just typically, once they get that high, that's their jam. Like, that's just what they want from now on, and they're going to do anything to get it. Right? So that's kind of addiction. So other things that can happen here. So for instance, there's tolerance. Right? What does tolerance mean? You get used to that normal effect of the opioid. And so say, for instance, the analgesic effects tend to sort of you get tolerant to that, right? So for instance, your pain, maybe, you may have chronic pain, you were 8 before you started taking oxycodone, and now you're down to a 4. But now you've kind of been on it for a while, and you creep back up to a 6. If you go back to your provider and you say, hey, I'm in more pain, I need more medication, what do you think their response is going to be? You're drug seeking, right? Or say, for instance, they have a refill too soon on their pain medication. You're going to think they're taking it inappropriately, and you're going to think they're drug seeking, right? Again, not always the case. A lot of it can be due to this tolerance that develops with these medications here. Some side effects, though, they'll get more tolerant to. So, for instance, these drugs tend to be pretty sedating. However, you have a lot of people who are driving trucks and driving cars and everything on opioids chronically because they get tolerant to the sedation sort of effects there, right? Not to say that everyone who's on opioids should be driving, because I definitely see some drivers out there who seem like they're on opioids, seem to be asleep at the wheel. But some things you won't never develop tolerance to. So like the constipation, it's always going to be a chronic thing they're going to run into with that. The other thing that kind of goes along with that tolerance is what we call pseudo addiction. That's kind of what I mentioned with the patients coming back and complaining, hey, I need more medication, or I need my dose adjusted, or something like that. Oftentimes, patients who maybe have chronic pain issues, maybe their daily activities have been limited to some degree. You give them opioids, they feel better, they can get up, walk around. That increased activity causes its own pain, right? And so they may have better functionality, but then or maybe the disease progresses or something, and now all of a sudden that same dose of medication is not working anymore for them. Again, it looks like addictive type behaviors, but it is not. How can you tell the difference? Well, someone you guys knew, because I don't, right? It can be very difficult, right? So it has to do with how good of a relationship you have with your patients. Oftentimes, with a lot of pain management places, they will have like pain contracts, where basically they're saying there's a contract between the provider and the patient saying, listen, these are the things you need to do to meet the requirements of this, and I will continue to prescribe this. If you violate any of these, you're kicked out of the practice. You're gone, right? So, for instance, I remember when I was on rotations and I was kind of shadowing with a pharmacist who worked in a pain management clinic, and they were talking about, like, urine drug screening a lot of their patients. Very frequently it's a random screening, because do scheduled screenings work? Not necessarily, right? So again, if they're using cocaine, they're selling their opioids for cocaine, and then they know they're going to get a drug test on Wednesday. Well, they can just stop using cocaine on Monday and they should be clear, right? Little things like that. They learn these things. And so, for instance, there's a patient who's on hydrocodone, and they said, we tested him for hydrocodone and he came back negative. And I was like, well, why would a patient who's on this medication test negative? And they're like, well, why do you think? I was like, oh, he's probably selling it, right? So, for instance, when my wife was doing her residency, she talked about this one guy who come into the pain management clinic. Older vet, was in one of those little, rascal scooter kind of deals. He'd come in and he always had this like girl on his lap coming in, and she was always like dressed to the nines. Very beautiful looking lady would come in on his lap, and all of a sudden one day the guy came back into the clinic and the lady was gone. What happened? Well, they stopped prescribing him his opioids, and then he was obviously selling those. And then once the money dried up, the lady was gone as well. So it was a very sad thing for the guy. Again, it's not typical, but again, those are some more notable cases there of some of the problems that develop from this, right? So again, that's why you may test these patients to make sure they actually are taking the medications you've prescribed them, because they may be selling them for something else, right? Whatever their addiction du jour happens to be. Maybe it's amphetamines, maybe it's cocaine, whatever the case may be, right? So again, there's a lot of facets that go into this, and it can be quite difficult to tell which patients are legitimate, which ones are not. And again, if you can find that way to tell the difference, then you're way ahead of the game than a lot of other people. So, as I mentioned, that pseudo-addiction very frequently associated with drug-seeking behavior, but typically once you get the management under control, once you actually get their pain back under control, then the behaviors kind of dry up, right? So it's just something just kind of be noted. Very difficult to tell. A lot of providers will become quite jaded to it and just say, I'm just not going to deal with it. I'm just not going to prescribe them whatsoever, right? So just depends on the case there. Now, it used to be easier for PAs, specifically because, could you guys always prescribe controlled substances in Florida? That's a recent development, right? Like 2018 was when 2017, when that actually came about. You could get your own DEA license. It was easy enough to say, well, I can't prescribe it. You may have to go to your attending to get a script or something like that, but basically you could just kind of say, well, I can't do that, right? But nowadays, if you have a DEA license, then you can be responsible for that sort of thing there. So again, this is why it's so good to know. Anyway, so again, question is, typically, is this addiction? Is it chemical dependency? Is it appropriate use? Basically, people who are addicted to opioids typically lose function, right? They lose their job, they're not taking care of their kids, they're losing function out of their life. People who have appropriate pain management but happen to have a chemical dependency, physical dependence on the drug, tend to regain function. That's kind of one of the big differences you'll see there. And again, you should expect physical dependence with all chronic opioid users. Now again, if you break your arm, you have 3 or 5 days of opioids, not going to be a big issue, but it's more these chronic low back pain or chronic neuropathic pain kind of patients you'll be seeing this in, right? And again, how do you tell the incidence of addiction? It can vary widely depending on the population, but anywhere between 1 to 50%. It's kind of a unknown how often that's going to really occur. However, what are some ways that you can help yourselves as a provider? Well, I don't know if I mentioned e-force before. Anyone know what this is?
How they regulate opioid prescribing and refills and where the patient's getting scripts from.
Right, so specifically it's the Prescription Drug Monitoring Program. And so this is a thing in Florida. And again, Florida's kind of late to the game in like almost everything. Like we're always like kind of the tail end of the wave of things. So like PA prescribing opioid or controlled substances was very late. E-force was extremely late. But basically this is a means of providers being able to go in, and I encourage you, and you'll pretty much have to if you prescribe any controlled substances, we'll go in and we'll register with E-force, and you'll be able to look up your patients and see any narcotic prescriptions they filled, any controlled substance they filled. You'll be able to find out where they filled it at, just within Florida at least, right? So this can be very useful, right? So a patient comes in and they're saying, hey, I'm having a lot of pain and I need some medication for this. I normally take morphine, but you know, I've been out of it. And you see that they've been filling very regularly, and you see that they have not filled in a while, things like that. That may lead you to think, hey, this patient is legitimate. If you found that they just filled 30 different scripts in the past month under different doctors, then that leads you to think maybe this is not legitimate, right? And so it's very hard to argue with a piece of paper if you can bring that to them and show them. So for instance, I had one patient, I was working in the ER, I was coming in for my shift, and you know, at the peds ER, you don't get a lot of adult patients, but sometimes patients will, you know, you get like a code triage, that's what they call if like an adult has like chest pain up in the clinic, and they bring them down and we triage them and get them stable, and we ship them out to an adult facility. And so we had a lady like that was there, and she was getting a dose of Dilaudid, hydromorphone. It was a pretty heavy duty opioid, and I was like, oh, it's kind of odd, I wonder what she's here for. So I went ahead and looked at it because I was verifying the order, and it was like for kidney stone pain. I was like, okay, well, it turns out she'd just been there like 2 days ago. She's like seeing her kid in the inpatient side and had pain then 2 days ago. To give her Dilaudid, shipped her out to an adult facility. The same thing happening today. I said, boy, that is strange. These kidney stones are so bad for this patient. So I said, I'm going to look up E-force. Pharmacists have also access to E-force as well. Really, any healthcare provider can do that. So I went ahead and looked it up, and sure enough, patient had been filling under various addresses, but all the same name, date of birth, had been filling at all these different pharmacies. It filled tons and tons and tons of oxycodone everywhere. So I said, huh, this looks illegitimate. So I went to the provider and I said, hey, have you checked E-force on this patient? This is before the House bill came out that changed this, and he was like, no, I hadn't checked it out. So I showed him, and he goes, oh, I can't believe it. And I go, hey, well, she goes, well, she was being so, she looked so believable, you know. And I was like, well, they get pretty believable if they're, you know, they can really fake that pain. Sometimes they'll even prick their finger and put blood into the urinalysis to show they have blood in the urine, right? Little things like that, little tricks in order to get around the system. And so he's like, well, she is not getting anything else from me. I was like, well, the 2 doses she already got, she's probably good until she gets transferred out. But anyway, so nowadays, though, now that the new House bill came out, I think 2018 is when that got released, now every single controlled substance prescription that you write for, you have to check E-force. And it's just good practice, right? You want to make sure your patients are filling things legitimately, not filling all over the state, right? Okay, so again, this is House Bill 21. This is the big thing that changed in 2018, and it applies to all controlled substances when you're prescribing in Florida. And basically, it includes taking certain education to get licensed to give controlled substances. And USPAs will have to do that anyway in order to get a DEA license, right? So you have to do that. And then you have to check E-force. Now, does anyone actually come about and enforce that? Not currently, but it's the expectations you'll do that. The other big thing that changed was how much you can prescribe for these patients here. So say you're working in the ER, patient comes in for an acute pain complaint, you are limited to a 3-day supply. So you only get 3 days at a maximum, okay? That may be extended to 7, but specifically on the script, you have to write acute pain exemption, okay? You should document in your note why you are giving this exemption, what reasons you have, because someone could come back and look at that and say, well, why did you do that, right? If you're giving any more than that 7 days, you have to write for non-acute pain. Now, has this actually changed how much prescribing has been going on of these opioids? I asked one of my friends, he does retail pharmacy, and he's working at works like an insurance company, like a particular insurance company where they have a lot of people in the local area that come just fill at them. And I was like, well, has that actually changed how much people are prescribing for? And he's like, no, most of the providers forget about it, so I have to call them up and I say, hey, can I put acute pain exemption on this? And they say, yeah, go ahead. And then he just writes it down. So who knows how much this is actually changing, how much enforcement will be going on, but it is intended to curtail how much we are actually prescribing such that patients have less access to these medications, because again, people will leave them sitting around if they don't use the full amount. Kids get into it, other adults get into it, it can be problematic. So those are the new restrictions placed on these scripts here. Okay, so remember we talked about federal scheduling of medications here. Remember there's C1 through C5. C1 means what? Schedule 1, but what does that mean? Remember? There's no acceptable medical use. Okay? And again, who regulates this? Not the FDA, but the DEA, right? So this is a federal scheduling, okay? So a Schedule 1 substance means it's a high abuse potential or high addiction potential, but no medical use, okay? So any ideas of some examples of a C1 medication, C1 drug? Say it again? Certain methamphetamines are actually Schedule 2, right? So there is a certain medical uses because we use a lot of amphetamines for ADHD, right? How about, marijuana? So federally, marijuana is still a Schedule 1 substance, right? That may change in the future, but currently is still Schedule 1. How about heroin? Heroin is considered a Schedule 1 substance. It has no acceptable medical use, and it is highly addictive, has a high abuse potential, right? C2, on the other hand, what's the difference between C1 and C2? There is an acceptable medical use, right? So the highest scheduling that you're going to be able to prescribe is a C2, right? Most of the opioids you'll be prescribing, if you do, will be a C2 medication, okay? Especially since oxycodone or hydrocodone got bumped up from a C3 to a C2, almost all of them are going to be C2s now, right? What does that do in terms of limitations on your prescribing? Huh? Yeah, so typically you will not write for more than a full 90 days at a time, and most of the time you would not write for that full amount on one script. But say for instance, like all of your amphetamines for ADHD, which we'll talk about in the behavioral section later, those are all C2s as well, right? And so do you want your patient coming back to you every single month to get a new script? Typically no, so what you actually do in those cases would be write for a month worth, and then you write 3 scripts, and you'll say, hey, do not fill this second one until a month from now. Do not fill this third one until 2 months from now. But 90 days is the maximum you can be writing for there, okay? Can you do any refills on those? Negative. No refills on C2s, okay? That's the big difference between those. Those have to be hand signed, and they have to be on that that paper that is like copy proof, or basically it's like a tamper evident paper. I mean, if someone tries to copy it, it says void all over it. Now there are means, some people are developing some electronic means, some secure ways to transmit these C2s via the interwebs, but for the most part you're going to be writing actual handwritten prescription, and you'll sign it with your actual handwriting at the bottom, right? So that's what it is with C2. C3s through 5s, what's the maximum you could write for there? Less than a year. 6 months, remember, so you can do refills on those, but only up to a maximum of 6 months. After that 6-month period, they're null and void, right? Because most non-controlled substances are how long? The scripts are good for how long? 1 year, right? So 1 year for non-controlled substances, 3 through 5, 6 months, no refills on a C2. And a C1, you cannot prescribe anyway, right? Everyone cool with that? How about cocaine? What is cocaine? Yeah, it's a Schedule 2 substance, right? So use it for some ENT surgeries and things like that, right? So anyways, let's get into the opioids themselves. We might not be able to cover all of them here before we end. The first one here is going to be codeine. Typically it's found in combination with Tylenol, and it's called Tylenol number 3. It has to do with the dosage there. This is one that itself is not really a very good analgesic, but it actually undergoes metabolism by an enzyme called CYP2D6 and gets converted over into morphine, which is good because morphine is a very good analgesic, right? So in that ways, you're going to find that some patients may be high expressors of CYP2D6. Some patients are not so great at metabolizing it. So people that are very good at metabolizing codeine into morphine, what do you think happens to the therapeutic effect of that drug? It works really well, right? Because you're converting a ton of it over, right? How about people who are slow metabolizers of CYP2D6? They don't get a whole lot of effect out of it. So it's very variable in terms of how much analgesic activity they'll actually get out of the drug. So there's some variability there. Some people respond really well to it, some people don't. And in fact, we've actually now taken this, basically in pediatrics, we do not use this anymore. right? We had some cases of death. I probably mentioned this before back in like probably the intro to Pharm class, but we had cases where these kids were actually undergoing tonsillectomies, and they already have OSA to begin with, right? They already have sleep apnea to start with, and now you're getting undergoing surgery. The airway's getting a little more edematous, and then now we're giving them codeine for their pain because again it's pretty mildly analgesic, above NSAIDs but not by much, and so they found was were not able to predict who was really good metabolized just at 2D6, and so they metabolize all this stuff over to morphine. And then we mentioned one of the really dangerous side effects of opioids is what? Respiratory depression. In patients who had OSA to begin with, their airways a little, more swollen than normal. So these kids were dying basically, right? They're basically dying in their sleep because of this. And so because we could not predict who was going to be a rapid metabolizer versus slow, we said, well, let's just not use it whatsoever. Typically, we did find that patients who have African American origin typically had higher expression of that. And so, which actually also makes a lot of sense because, again, if you think about like sickle cell disease, Black patients typically are more likely to have sickle cell, and actually a lot of them respond really well to codeine. And that makes a lot of sense because, okay, well, they're more likely to convert that stuff over to morphine anyway. Makes sense why they would be well controlled on that medication. So for the most part, we've gotten away from that in pediatrics just because we can't tell who's going to respond well and who's not. Most of the time, this is going to be a C5 for the majority. And in fact, if you were to take like a 3-day cruise and hit Nassau up, you can actually go buy this over the counter in their pharmacies. So again, it can change depending on where you're at. Anyway, so because of that, again, we generally avoid this because patients who are ultra rapid metabolized just at 2D6 in kids, Middle Eastern, North African descent tend to be more likely to express that. But again, it's hard to predict because we don't test for it normally. Okay, so getting into morphine, something we do use quite commonly. This is another pretty good go-to workhorse sort of opioid. It's available in a ton of different formulations. We have IV, PO, you can have immediate release morphine, you can have extended release morphine, all kinds of varieties are available here. And so if you see things like MS Cotton, that's typically the oral long-acting form that you might see pretty commonly there. So its metabolism, kind of two different metabolites that get shown up here. You have morphine 3 and morphine 6 glucuronide. The interesting one here is the morphine 6 glucuronide. That is one that is produced, but it's an active metabolite. Right? What does that mean? Not only is the morphine itself hitting those opioid receptors, but this metabolite also can hit it and has really good analgesic properties. Sounds all well and good, but the problem is if you have renal dysfunction, you can actually accumulate that metabolite, and what does that increase your risk for? CNS and respiratory depression, and all the other side effects that go along with it. So this is one we don't necessarily like a lot in elderly patients because they're more likely to accumulate those metabolites chronically, and they can actually lead to some severe toxicity because of that. So that's one consideration to make there. And then the other big thing with morphine is that it causes a significant amount of histamine release. So you have a lot of patients will say I have a morphine allergy when really it's just they have a lot of itching and maybe a little bit of pruritus associated and some rash associated with the actual histamine release there. How can I treat that? Get some Benadryl, right? But you may even see things like their blood pressure drop a little bit because of this, because of that histamine causing vasodilation. So again, if they have that history, may not be the best drug to use for those patients there. But not necessarily a true like anaphylactic allergy. You want to make sure to discern between that. Now, switching gears, and then we have hydrocodone. This is very frequently, especially when it was a C3, it was the most prescribed drug in the U.S., right? Because again, you go to the ER, you have pain concerns, get a prescription for Lortab, get a prescription for Norco. Very often, you're only going to find this formulated with Tylenol. Okay, so hydrocodone, Tylenol. There's a couple formulations now for chronic pain that are by itself, like Zohydro ER is like an extended release formulation that has just gobs and gobs of hydrocodone in it. But for the most part, you'll see things like hydrocodone 5, 325, 7.5, 325, 10, 325. The 10, 7.5, or 5, that's a hydrocodone component. The 325 is what? That's the Tylenol, right? It used to be 500. So you'd have like hydrocodone 500. We lowered that down and we got rid of all of the 500 milligram of acetaminophen containing formulations because why? What do you think? Yeah, people are getting too much acetaminophen, right? So they're either taking too much Lortab by itself or they were taking Tylenol on top of that. And so by limiting the amount of acetaminophen we put in these products, that helps to mitigate some of that toxicity. So that's the reason why you're only going to see the 325s anymore. Now, I will tell you that did I ever tell you my second day working retail in pharmacy? So actually my between my first and second year of pharmacy school, I was interning at a CVS. And it was not like the sketchiest part of Jacksonville, but it was not like the nicest part either. And my second day working there was like a Saturday. We actually had a guy come in. We were getting a delivery on the weekend, which is kind of like weird. And so like the door was open, and this guy comes in, and like it was like the middle of Florida summer, so it was like 1,000 degrees outside. Guy had a big sweater on, had a ski cap, had glasses on, and most notably a knife. And he said, where's the hydrocodone? And I said, it is right there. You should go. And so he ended up like stealing like 2 big 500 count bottles of the stuff and running out. And it was like me, like a grad intern who was like just out of school, and our pharmacist who was like maybe like 90 pounds sopping wet, and she decides to go running after the guy to see what his license plate was. And I was like, what are you doing? Like, no. But she got it, gave it to the police, and sure enough, they caught the guy, and he had like a 10-month-old at the house he left when he came to rob us. Like, bad stuff, right? So obviously an addicted individual. But anyway, so I didn't die, but I said, retail's probably not for me, and I'm going to go work in the hospital. And if I get robbed there, then I'm just out of pharmacy completely. So I'm still here, so nothing happened bad after that. But anyway, the hydrocodone, it does get metabolized in the liver via CYP2D6 to hydromorphone, which was another one we'll talk about. It's called Dilaudid, is the common brand name there. And so again, you'll see some of that variability in response. It's not nearly to the same degree as codeine would be, but you still see a little bit of variability there, right? Now again, it used to be a C3, got bumped up to a C2 because that was part of that opioid epidemic. We were trying to curtail how much we were really prescribing. Because as a C3, I could give you 6 months worth of hydrocodone. That is too much for a lot of patients, right? So because they bumped up to a C2, really limited how much you'd be able to send out there, right, in terms of scripts. Now oxycodone is frequently found either by itself or in combination with acetaminophen. So if you see like Roxyset or Percocet, that set means acetaminophen, right? That's how you know it has acetaminophen contained in it. When it's by itself, it's either like Roxycodone by itself, or if you see like Oxycontin. Oxycontin is the extended release variety thereof, okay? So, and in fact, I am suggest if you're interested in the topic, there's some good, I don't know if you guys watched Last Week Tonight with John Oliver, but he has some YouTube clips up where he talks about the opioid crisis, and he talks about Oxycontin specifically, and has just one drug manufacturer who brought it out. The thing with Oxycontin, and why it helped to contribute a lot to the opioid epidemic as it stands now, is because originally when they were testing it, they found that really to get good pain coverage, you really needed to dose the drug every 8 hours. But the marketing people didn't like that. They said, no, we need to market this as every 12 hours. That way you only give it twice a day, you get full 24-hour coverage. And so all the marketing said that, all the drug reps came out saying that. They were trying to basically, trying to think of the word, talk to all the docs, try to what's the word? I'm trying to persuade somebody, maybe real schmoozy. It was kind of coercion a little bit, right? But basically they were like sending them to big dinners and giving them golf clubs and all those kind of things. They say, listen, every 12 hours, twice a day, Oxycontin's great, right? And so because of that, a lot of patients were not getting sufficient coverage. Towards the end of that 8-hour period, guess what? Pain started coming back, right? So what did they start doing? They started dosing themselves, right? So again, they would start to manage their own pain, because what the prescription was just not covering it, and so that led to, they think, to a lot of the addiction that we're seeing nowadays. And so there's a lot of interesting backstory to that, but I suggest checking out doing a nice YouTube dive on that stuff if you find this interesting, because it really is affecting a lot of facets of our lives nowadays and how you're going to be practicing in a lot of cases there. But anyway, so Oxycontin's a long-acting form. You'll see that quite frequently, maybe every 12 hours, every 8 hours, and then you may have like immediate release oxycodone on top of that, and that's usually for that breakthrough pain there, okay? Again, this one gets metabolized to a small degree over to oxymorphone, so you may see a little bit of variability. Some patients may respond better to that one or less so than others. Now, hydromorphone itself, or Dilaudid, this one is going to have some metabolites, but clinically this doesn't come up so frequently. You may see a little bit of myoclonus if you have patients who are accumulating that 3-glucuronide formulation, but honestly doesn't come up very often. This one has a shorter half-life than morphine. And why do you think that might be beneficial to use something that has a shorter half-life? We can like titrate it a little bit better, right? So for instance, if I have patients who are, say for instance, they're post-surgical and they are on a continuous infusion of hydromorphone, I can titrate that a lot better than something that's a little bit more long-acting. So that's one case there. This also causes a lot less histamine release. than morphine does. So I see a lot of patients will be using this as an alternative if they have a history of itching or pruritus associated with morphine itself. And I see a lot more of this being used, especially a lot of our sicklers, sickle cell patients. A lot of them are using hydromorphone as kind of their go-to. There's IV oral formulations are available. So overall, it's a pretty good drug. A lot of surgical use certainly. So you'll see this quite often when you get out there in clinical practice. Now, fentanyl is a big one, right? So fentanyl typically gets reserved for more like surgical use. We use a lot in the ER as well. We'll actually use intranasal fentanyl if we have patients who are having significant pain and they don't have IV access yet. That can be one alternative to doing that. This stuff is extremely potent, right? So 100 times more potent than morphine. So if you think about therapeutic doses, say morphine between like 2 and 5 milligrams. Morphine's a pretty good analgesic dose for most patients. For fentanyl, you're thinking more like 25 to 100, maybe 200 in some rare cases, micrograms. Okay, very small amounts. That means you gotta be careful when you're prescribing. One time, I had a doc who was trying to order for a surgery patient. Most of the time, it's all computerized systems. The units will have options for patients. So if you wanted to write for 50 micrograms, you'd hit 50 in the box, and the second box you'd hit micrograms, you'd be good to go. There's other options like mics per kilo per dose. Okay, so what this provider had intended to do was to write for 50 micrograms of the drug, but instead had 50 mics per kilo per dose. So when it came up as 2 milligrams of fentanyl, I mean, that's probably enough to kill most of the people in this room right now. Obviously, that was a bit of a boo-boo, so we corrected that. But you have to be really careful when ordering this stuff because 2 milligrams of fentanyl may not sound like much if you're thinking morphine, but it is quite a lot, right? So very, very potent. We have a lot of different dosage forms that are available. So we have IV forms. You see a lot used in surgery in the ER setting. We have transdermal formulations. So if you ever heard of like a Duragesic patch, that is something that will provide nice continuous around-the-clock coverage with fentanyl transdermally. We even have transmucosal. Here's the fentanyl lollipop for chronic pain patients. This allows them to kind of titrate their dose. Having pain, put it in by their cheek. It'll absorb a little bit. Pain goes away. Take it out, right? Obviously, might that be a bad idea for? Anyone with children. Kids like to mimic their parents quite frequently, and so if they see the parents or grandparents using that, they may want to try to use it as well, right? So like my kids see me brush my teeth, all of a sudden they want to brush their teeth. See me use deodorant, now they want to use deodorant. It's quite cute until I'm using my fentanyl lollipop, and then they want to use it too. Anyway, the other thing with transdermal formulations, you got to be really careful and make sure you really examine your patients. So we have a lot of patients who may show up to the ER, they come in via EMS for altered mental status, or they found unconscious out in the field. You got to do a full head-to-toe exam for these patients. They could have a fentanyl patch on them somewhere. If you don't catch that, as a continued administration of that drug that needs to be eliminated, right? So another important thing to consider there. And we use this all the time for acute pain, specifically IV, like in more surgical settings, inpatient settings. But again, the long-acting forms, transdermal, things like that are going to be more for outpatient, more chronic management for those guys there. Now now my dad, he's actually a CRNA. He's retired CRNA now, but so I always got like the good anesthesia jokes and things like that from him, like the Ether Bunny. He had a T-shirt that had the Ether Bunny on it. Anyway, but he always talked about fentanyl and fentanyl's brothers and sisters. So there's Al, Sue, and Remy. So alfentanil, sufentanil, and remifentanil. If you have any doubt as to where I got my sense of humor from or lack thereof, you can blame him. Anyway, point being that these are varieties you might see being used specifically in the surgical realm. And so, for instance, when we have our patients go down for cardiac surgery, they use sufentanil drips exclusively. So it just depends on the provider, what they're used to, what's available. But anything that ends with a fentanyl on it is basically a fentanyl derivative, right? So very potent microgram dosing you're seeing there. And in fact, the reason why you see so much fentanyl deaths nowadays is because it is so potent. So we get a lot of fentanyl coming in from other places like China and places like that, where a kilogram of morphine certainly is a lot of morphine, but a kilogram of fentanyl is roughly equivalent to 100 times that, right? So easy to get in a lot of product here, and then so you start to cut your heroin with fentanyl. And again, I don't know if I trust drug dealers to be the most conscious of quality control, making sure that the right amount of fentanyl gets into every single dose. But it's very easy to see why patients may get their normal dose of heroin, not realize how much fentanyl is in it, and then all of a sudden they die from it, right? So it is a very common thing you're going to see out there with a lot of heroin users. But this is a very synthetic form of opioid. So whereas things like morphine and codeine look a lot like the opium that comes from the poppy plant, this is a fully synthetic variety. It does not look anything like the chemical structure of morphine. And as such, if you have a patient who has a true anaphylactic allergy to morphine, they can receive this safely. So we'll use it as an alternative if a patient have a true morphine allergy. This is a good option for them. Up next we have methadone. Anyone know what we use methadone for? Typically we use this for opioid addiction if we're trying to wean patients off of their opioids, right? This has a couple different mechanisms. It has some activity with like glutamate receptors, like the NMDA receptor. Has some activity in blocking serotonin and norepinephrine uptake. But the main key to its features here is that it has an extremely long half-life. So over 50 hours or so. So why is that good for patients who might be withdrawing from opioids? Well, it builds in its own nice natural taper, right? So, and again, when you have these patients who are trying to wean themselves off opioids, you typically will have what they call direct observed therapy, where they have to go into the methadone clinic and actually receive the medication there, right? And so what ends up happening, and the nice thing about this is that, say for instance, you're looking at blood levels of methadone over the week, and say, you know, they go on Monday, they get their dose, and start to come down, and they go on Tuesday to get their dose, and Wednesday, Thursday, and Friday, so they have this nice high level, and then, well, the clinic's closed on the weekend. So now they have this high level, it just kind of naturally rides down until the clinic's open there on Monday. And let me tell you what, Monday at the methadone clinic is hopping, right? Because people are starting to, like, you know, the levels are getting a little bit lower, they're starting to get a little bit of that itchiness, their nose is starting to run a little bit, they feel that withdrawal coming on, they want to get their dose, right? But that's the benefit of it. It has a nice long half-life, and even if they miss a dose, it has a nice natural taper to it. You're not going to see the acute, abrupt withdrawal like you would with, say, morphine or fentanyl or something like that, right? So that's one of the things we like to use it for. This is, nowadays, we're starting to see more use for this for chronic pain than anything else, because it's still a good analgesic. It still works just as well as any of the other ones. So you may find some patients who are taking methadone, say, Q daily, while having, say, PRN, oxycodone, immediate release, say, for breakthrough pain, right? So you may see that combination that will develop there because you're seeing more and more chronic use. If you're going to use methadone for opioid addiction, you have to have special certifications. You have to be within an addiction center to do that. If you're using this for chronic pain, no such restrictions apply. So you as a PA could potentially be prescribing methadone for these patients there for pain purposes, but probably not for, you know, opioid addiction purposes. So again, there's a little caveat to go into that. Anyway, one of the things to always note there is that you can see QT prolongation with this, right? And that puts us at risk for what? For SODs, right? So you always got to check patients, check an EKG at baseline, especially if they have multiple medications that can prolong QT, because that's when you get into problems there, okay? And just be aware of, you know, especially if you have, say you're working in the ER, and you have a patient comes in and say, oh, I'm on methadone. You ask them, okay, what's your methadone dose? And say, I'm on 50 milligrams every day, which is a high dose, but it's not unheard of, right? Because of that tolerance, you can build up really high doses, build up to really high doses. You just go ahead and say, okay, well, I'm going to go ahead and admit you, and we're going to just re-prescribe that. Why not? You got to double check their dose, right? You have to make sure you call the clinic, or you have to check eForce and make sure you're giving them the right dose, because they're lying to you. We had cases of this where we had over at ORMC, there was a case I know of where a patient came in and said, this is my methadone dose, and there they have a MedRec program where they have pharmacy technicians who will do the MedRec with the patients in the ER. They'll go and transmit that to the pharmacist. Pharmacists will verify it, put it into the chart, and then the providers will, whoever's admitting, will reorder things as appropriate. So the pharmacy tech, who doesn't know any better, got history, hey, they're on this really high dose, but they don't know any different. Go tell the pharmacist. Pharmacist says, well, it's high, but it's not unheard of. Let's go ahead and put that in the chart, and then the provider reordered it. They found the patient comatose basically the next morning after receiving that high of a dose that was much higher than what they would normally get. They had to give Narcan, reverse it, and all. You know, it's kind of a big thing to do. So you got to be really careful with this. Make sure you double check on their doses that they're telling you. One you may see used occasionally is called meperidine or Demerol. This is one that almost should never be used. It has a lot of issues, and I had one pain management pharmacist in school who called this Demonol because she hated it so much. Mainly because a lot of older patients who have poor kidney function will develop metabolites and they'll build up, and they can cause seizures and cause some cardiac toxicity as well. So we don't like this quite as much. However, there's one case you may use this, especially if you work in surgery. You can use it to treat rigors. You know what rigors are? Shivering, basically. Yeah, so you come out of surgery, normally keep the ORs pretty chilly. Patient may be shivering. You can give them this for rigors. We have patients who will undergo what we call therapeutic hypothermia. Anyone ever heard of that? Somebody will do it for like stroke, sometimes for MIs and things like that. You cool the patient down to try to preserve them, essentially. And so when your body gets cold, what does it do to try to build heat back up? You shiver, right? So we can either paralyze the patient, or we can give them a parodine, and it'll help to stop that shivering from occurring. So that's one use you might see for that, but again, rarely used ever because of the seizure risk that happens in the elderly patients. Another one's called buprenorphine. This one is going to be another fairly long-acting agent, and most often this is going to be used for opioid addiction. That's kind of its only real use. The thing that differentiates this from methadone is the fact that it's a partial agonist. Okay, so why do you think that would be useful for patients who are addicted to opioids? Because it's a partial agonist, but it binds really tight to that receptor. It has really high affinity. Precisely, right. So if they were to say be on buprenorphine and they were to take, say, heroin on top of that, those receptors would be occupied by the drug, and thus the heroin might not really work that well. Okay, that's the benefit of using a partial agonist. The problem, though, is that you have to give it at certain times. So, for instance, if I have a patient who is, say, using oxycodone every day, and then they come into clinic, I'm going to switch them right over from a full agonist to a partial agonist, what would happen? You can put them into withdrawal, right? Because again, they're going from 100% activity to maybe 50% activity. That's going to put them into withdrawal. You don't want to do that. And so what frequently happens when you're trying to start patients on buprenorphine is you'll let them, you tell them to stop taking their medications, any opioids, and then once they start to have withdrawal symptoms, then you start them on this, right? And that will help to ameliorate those symptoms, prevent them from withdrawing, and then you can start the process of weaning them down off the buprenorphine, okay? So that's how it's being used most commonly. We have even things like implants that we'll put in. So that way you have nice, you don't have to worry about compliance because it's there. It's going to be slowly releasing the drug over time. But we've had patients before where you'll say, okay, listen, like, we're going to put this implant into you, and you cannot have been using any opioids beforehand because you will go into withdrawal. If you do this, it's going to be very bad for you. I say, okay, great. Guess what? Come and get the implant. They lied. They were using opioids the day, right up until they were getting the implant, and basically they go into withdrawal. And what happens when you put that implant in? Well, it's kind of there. We're not going to just take it out because of that. So patients are quite miserable because of it, but it's been certainly reported. So you have to be really careful with that. The other thing that's really significant with this one is that, like, if kids get into it, it can be really, really significant. I mean, any of these can be dangerous if kids accidentally get into it, but this one you can have sedation for up to 24 hours in some of these kids, even after a single dose. So I really recommend being very careful with this drug if you have any children anywhere near the stuff here. Anyway, and then you may see occasionally co-formulated with naloxone. Naloxone is going to be the antagonist we'll talk about in a little bit, but basically it's meant to deter IV abuse. Naloxone itself doesn't get absorbed from the GI tract, so if they were to take it orally, naloxone doesn't do anything. They get the buprenorphine benefits. They try to inject it, the naloxone should help to prevent the buprenorphine from working so well. And so that's meant to deter IV abuse there. Well, what's the problem with IV abuse of opioids? They share needles, right? Or they have unsafe practices. And you can see things like endocarditis. You can see things like Hep C, HIV, all kinds of diseases that can be spread or caused by IV abuse of medications. So definitely try to prevent that as best we can. Okay, so that's all I got in me for today. Any questions so far? So we covered the main opioids we were going to talk about. We'll get into how we use them and how we can reverse them next time we meet. I put up the prescription assignment there, and I think we have a quiz in 2 weeks, but check your syllabus for the schedule. It's definitely not next week. I would not be that mean. Okay, let's see if we have any questions. Can you wean the patient off methadone eventually? Yeah, you probably should, but it depends on your use. If you're using it for chronic management of pain, then you may not want to do that, right? Maybe you want to just keep them on that, and that's just what they're going to use for their kind of basal control. But yeah, eventually, once you start the patient on methadone, you'd want to wean them off. Now, I was talking to a gentleman one time, and he said that he had no idea. But one time, his son came up to him, and he's probably in his 30s, and he said, "Dad, I got a problem, and I've been addicted to opioids for a while." And the guy had no idea about it, and so he was trying to help him out. They got him hooked up with the methadone clinic. But it was interesting because it's one of those things where the methadone clinic, they make money from patients coming in, so there's kind of a financial incentive to keep them coming back to you, right? So he had a kind of a conspiracy theory thinking that, well, I don't know how fast they're actually doing this wean, but it seems a little bit slower than maybe if you tried other methods. But anywho, yeah, the goal is to eventually wean them off of their dose so where they'd be opioid free at some point. Right. Any other questions or anything? Yes.
So for the class change in the disease,
The what?
if someone's going to go to pain management, are they able to have a class 2 for a longer period of time?
So yeah, so in those cases there, you'd say, okay, I'm going to write for non-acute pain on the script, and then it would be under this normal restrictions for a C2. So you'd probably write for a month at a time, up to a maximum of that 90 days, and they would just have to come back. And a lot of times you do want them to come back pretty frequently to keep an eye on them. If they have a pain contract, frequently they have random urine drug screens they're going to be doing. So they'll just get a random call on a day, say, hey, come on, do a drug screen. If not, then you're kicked out of the program, right? So it just depends on if they have that history of substance abuse, what the contract says, things like that.
And then if someone's on palliative care, the restrictions lifted a little bit?
Well, if they're in palliative care, typically, if they're like in a hospice type of setting, then it's more like an inpatient setting, right? So you don't have to worry about the scripts necessarily. But yeah, certainly for palliative care, you could say for non-acute pain, and that makes sense, right? So certainly you're documenting everything in their notes, saying, hey, they have terminal cancer, blah blah blah. I'm prescribing this because X, Y, and Z. Yeah. Any other question? There's still restrictions for sure, right? So and it's really tough too for the patients because for instance, when hydrocodone made the switch to a C2, it became a lot more tough. So when our patients were coming out of surgery and the docs were writing for them to go home with a script for liquid hydrocodone, right? So there's a liquid formulation there. There was something where, if you call a pharmacy and ask them, hey, and it wasn't something a lot of people carried. So if you go to a pharmacy, you call them up and say, hey, do you have this medication in it? It's a C2. They're going to say, we're out, or I can't tell you that, right? Because why? What do you think? Because you don't want someone coming to rob you, right? So very frequently, we're not going to be too chatty about our stock of controlled medications. But the parent was like, my kid's in pain, I want them to get something. So we actually had to make sure we had a pharmacy that we were having an agreement with, saying, hey, listen, we'll send our patients to you if you carry this medication for us, if you can assure us that, so that way they can have easy access to it, right? So little things like that can make it quite difficult to get the appropriate pain management. But, if you just take a random script, imagine, here in Florida, we have a lot of travelers. If I get an out-of-state prescription for a C2 medication, I'm not going to want to fill that. I'm going to think it's something illegitimate, right? So there's a lot that goes into it. It can be very, very tough. Patients say, oh, my medication, the dog got into them. It happens, but, again, it's really tough. I'd always have calls to the poison center. We would do pill IDs for patients, right? Because we figured overall it's safer to identify the pill and let them know what it is rather than not, and they're taking something totally random, right? And so we'd have people call in and they didn't want to get in trouble. And so I found this pill, I think my dog might have gotten into it. Can you tell me what it is? And so it'd be like an Oxycontin 80 or something. It's like just a gobsmacking amount of oxycodone, right? And I'd be like, okay, did your dog legit get into this? Because if not, that's okay. I'll still tell you what it is, but legit let me know, did the dog get into it? And they're just like, yeah, maybe, I think so. It was just like, okay, this is a totally different call if there might have been an exposure versus you just want to know. I don't really care if you want to know. But, people are, very worried about litigious issues, things like that, but it is what it is. Okay, if nothing else, I will see you guys next time.